So let's start with this. Newborns with hyperglycemia in utero are at risk for A, being born small for their gestational age, B, gastroschisis, or C, respiratory distress syndrome. So let's talk, as you guys are thinking about what the answer is, or you already know the answer, let's talk a little bit about fetal hyperglycemia. So what is happening when we have a fetus of a diabetic mother? If mom is hyperglycemic, all that extra glucose is readily crossing the placenta to the umbilicus to the fetus. But insulin is actually a really large molecule and it doesn't cross. So all the extra insulin mom is either producing herself or taking doesn't get to the fetus. So with all of that extra glucose going to the fetus, that baby's or fetus's pancreas is functioning and it's going to create lots and lots of insulin. So what do we see? We see babies who are big, they're macrosomic, right? Because they are macrosomic, sometimes we see birth trauma. Sometimes the baby has trouble getting out. Of course, we can see hypoglycemia because as soon as we cut that umbilical cord, now the baby is no longer receiving all that glucose and their pancreas is still producing lots and lots of insulin. So we commonly see hypoglycemia, and I think that's something that we think about all the time. Some other things that we can see are metabolic and electrolyte abnormalities. So these babies can commonly have hypocalcemia, hypomagnesemia, and these are more commonly seen after like 48 to 72 hours. And it's believed to be that there's a failure to mount the appropriate amount of parathyroid hormone response. And then there can also be persistently high levels of calcitonin and also possibly alterations in vitamin D metabolism. So the hypocalcemia and hypomagnesemia are usually pretty transient, but none of those were our responses. I feel like sometimes when we're taking these tests, we have things that we expect to see, like, okay, the fetus was hyperglycemic, therefore I'm going to see hypoglycemia, or I'm going to see a big baby, but none of those were our responses. So what else could be happening? So other things that we think about with the fetus having that hyperinsulin level is that it can affect a lot of different systems. So hyperinsulinemia also suppresses surfactant production. That predisposes them to respiratory distress syndrome. So good job, Roxana, who got it right, that the answer was C, respiratory distress syndrome. Hyperinsulinism or hyperinsulinemia in the fetus can also cause increased erythropoiesis or increased red blood cell production. And basically what happens is there's an increase in fetal metabolism and there's increased uptake of oxygen at the tissue. And that kind of triggers a kind of hypoxemic state for that fetus. And when the fetus or the body is in a hypoxemic state, the body's going to produce more red blood cells so that it can circulate more oxygen. So for this baby with hyperinsulinism, that's what's happening. They are creating more and more red blood cells, putting them at risk for polycythemia and hyperbilirubinemia, because we know if we have more red blood cells, we have more breakdown of red blood cells, and we have more bilirubin. And then we can also see different cardiac defects and congenital malformations. I always like to remember that insulin is actually a human growth hormone. So that's another reason that we have these big babies. And also we can have septal hypertrophy and cardiomegaly, big heart as well, for these little, usually not little babies, sweet little guys. So with that, the answer to number one is respiratory distress syndrome. So yay, good job if you got it right. Let's continue to our next question. Any questions on that? All right, feel free to, oops, I went the wrong way. Feel free to ask and we'll continue. Number two. So analyze the following blood gas value. pH is 7.38, CO2 is 27, bicarb is 16. Is it a compensated metabolic acidosis, a compensated respiratory acidosis, or a uncompensated metabolic acidosis? Blood gases are one of those things that I always need to write it out for myself. Like I like to use little arrows. Different people have cool different tricks that they'll use. If you've ever taken the stable program, they have that really great nomogram. So let's go through it together. So here on the side, I have our normal values. And I like to just break it down one at a time. So looking at our pH, 7.38 is normal, right? If our pH is normal, that tells us that the blood gas is normal or that the blood gas is compensating, okay? So now let's go, our CO2 is 27. So our CO2 is low. So our baby is either hyperventilating or they are being overventilated. So for some reason, this baby's blowing off lots of CO2. And then our bicarb is also low. So in this case, our bicarbonate is the primary problem, and the baby is trying to compensate for our low bicarbonate by blowing off more CO2 or blowing off more acid, which is actually bringing the pH up from being acidotic. So this baby has a compensated metabolic acidosis. And I don't know about you guys, but sometimes I could get confused about like, how do I know which is the primary problem, respiratory versus metabolic, when I'm looking at this? I put on this, you can just cross out right away, C, because we knew it was an uncompensated metabolic because our pH was normal, okay? Let's talk about how do we figure out what is the primary problem? What is driving the acidosis? So I heard somebody use this little, I guess it's an acronym, ROAM, and that kind of can help you understand how the CO2 and the bicarbonate affect the pH. So if the respiratory and the pH is opposite directions, then that is the primary problem. So if the pH, for example, is low and the CO2 is high, then we have a respiratory problem. If it's a metabolic problem, then the bicarbonate and the pH are going the same direction. So if the pH is low, like in our scenario, and the bicarbonate is low, then it's a metabolic problem. And I actually had a really amazing instructor when I was in my CNS program. Her name's Dr. Jana. She's wonderful. If you ever see her speak at a conference, go hear her because she's just excellent. And she would have us do, like, if you've ever done the Saturday Night Live, like, staying alive, she would have us do that, like, as we were doing the pH. So for example, for this question, our pH 7.38. So that would be more on the lower side, even though it's compensated. It's normal, but it's towards the acidosis. CO2 is low, so we know it's not respiratory, and bicarbonate is low. So then we have metabolic. That always stayed with me, just the movements for how do I know if it's respiratory or metabolic. Okay, hopefully that was helpful for you guys. All right, question number 3. This one somebody sent me on Instagram. And what is the difference between NIPPV and CPAP? So A is CPAP and NIPPV are essentially the same, except CPAP is delivered with a mask and NIPPV is delivered with prongs. B, CPAP provides constant descending pressure, whereas NIPPV only provides intermittent breaths without constant descending pressure. Or C, CPAP provides constant descending pressure, whereas NIPPV provides constant descending pressure with peak intervals above to mimic tidal volumes. Ooh, that one's kind of long to read. Good job, guys. So we got a few people saying C. Yeah, you're right. So it's C. So if you look at A, we know that's not right because CPAP, depending on where you work, there's a lot of different interfaces we can use. We can, in the delivery room, we may use a mask. In the NICU, we may use prongs. And you can use all kinds of different interfaces. So A is not right. B is saying that CPAP provides constant descending pressure and NIPPV only provides intermittent breaths. And that's not true because NIPPV is providing both the constant descending pressure as well as the breaths and the tidal volumes and the pressures that we need. And so here we can see some of the kind of comparisons, NIPPV and CPAP. CPAP provides that, again, constant descending pressure. Other terms you might hear is functional residual capacity. It's keeping the alveoli open and supporting that baby's breath. It can also help maintain upper airway stability. So sometimes we have babies with like a laryngeal malacia where their airway is just really floppy, and they can be on CPAP truly just to stent their airway open. Whereas NIPPV, it's our more non-invasive method of positive pressure ventilation. So we give a PEEP, which is the constant descending pressure, or the CPAP, as well as the PIP, the inspiratory pressure, and a rate to go along with it, right? So that's the difference. CPAP is only that PEEP, whereas NIPPV, you have the rate, you have the PIP, you have the PEEP, you have all of it. So, and of course, you can adjust your FiO2 on either. There was, if any of you guys listen, the Incubator podcast, I think it was last week, they had a whole series on supporting babies with respiratory distress. And they had talks about high flow nasal cannula and CPAP and NIPPV and intubation and early extubation. And it was really good. I haven't gotten to listen to all of the episodes yet, but if you like podcasts, I highly recommend it. I like to listen to them on my way to work. All right. Moving on, question number 4. We're flying through these. You are caring for a newborn who is small for their gestational age, has hepatomegaly and blueberry muffin spots. This is most likely due to A, congenital viral infection, B, neonatal alloimmune thrombocytopenia, or C, traumatic delivery. You guys are so smart. It's A, you're right. Congenital viral infection. So some of our congenital viral infections are CMV or rubella, and they can present with dermatologic findings like a blueberry muffin spots. I feel like almost everybody I've talked to has had some sort of blueberry muffin spot question on their RNC. I know I had one, it was like within my first couple of questions, it was a blueberry muffin spot question. I don't know why, I feel like that just always comes up. So what are these spots? Basically, they're caused by thrombocytopenia and a dermal erythropoiesis, so that production of red blood cells. And then hepatosplenomegaly is also an associated finding that we can see with babies with congenital viral infections. And so the acronym that you think of for these congenital viral infections is TORCH. And TORCH stands for toxoplasmosis, other, which encompasses a bunch of other infections, rubella, CMV, and herpes simplex virus. And some of the common manifestations that make people really look for like a TORCH infection is IUGR, babies who are born small, hepatosplenomegaly, if they have the rash, like the blueberry muffin, if they're jaundice, or if they have thrombocytopenia. And then here on this little table, I created just some of the manifestations for these different conditions, these different viral infections. And also I've seen where some people have extended the acronym. So I think it's the core curriculum book that you'll see, they call it TORCH's CLAP. And that's what I have in my course, just to really, because you think other, and it's easy to forget some of them. And I also highlighted syphilis because that's really, really prevalent. I don't know about you guys, but in the last couple of years, I've seen babies with congenital syphilis much, much more than I did when I was a new grad. So syphilis, I think, would be a really good question to ask on. I'm not a test writer. I don't do anything for NTC, so I can't say what they write test questions on, but syphilis is a really good one because it's so highly prevalent right now. And then CMV too.